السلام عليكم. المحاضرة لهذا اليوم عن Acute Flaccid Paralysis. The objectives of this lecture is to define acute flaccid paralysis, to demonstrate an appropriate approach to the clinical and diagnostic workup, to outline the clinical course in two main examples, two common examples or main examples encountered in the pediatric neurology or pediatric field, the Guillain-Barré syndrome and the poliomyelitis. We will outline the clinical course, we will review the diagnostic workup, and discuss the treatment of both of them. And finally, we will summarize the prognosis of Guillain-Barré syndrome. Definition of acute flaccid paralysis is a rapid evolution of motor weakness within less than 4 days with a loss of tone in the paralyzed limbs. So there is paralysis and there is hypotonia or flaccidity. And we will exclude the trauma and the spastic paralysis as causes of weakness. It is a medical emergency. This is very important. Once you encounter such a child, you need to hospitalize him and to formally and precisely approach that patient. This is a formal or a simple clinical approach to that subject or that type of children. If you decide that this child has no CNS symptomatology and no sign and symptoms of CNS weakness, then the child has acute problem with the inability to walk, and you are going to examine this child. You will start with the following steps. You will first consider the sphincteric changes or sphincteric function. If the sphincteric functions are preserved, okay, or if it is affected, then most likely you are, or the problem in the spinal cord, most likely the problem in the spinal cord. But there is an exception we will talk about later. And then you will check the sensory loss. But remember that this is difficult to be checked or to be assessed precisely and accurately in children. But we have to move to the second step, the sensory loss. If there is dermatomal sensory loss, the problem in the spinal cord most likely. If it is if there is dermatomal sensory loss with a sphincteric dysfunction, then most likely the lesion in the spinal cord. If there is dermatomal sensory loss and the sphincter is preserved, again you are in the spinal cord. So the spinal cord lesion can affect the sphincter function or can be associated with a preserved sphincteric function. If there is glove and stocking pattern of sensory loss with preserved sphincteric function, then the problem is in the peripheral nerve. If there is no sensory loss and the sphincteric function is preserved, then move to the third step. The third step is the reflexes. The reflexes تحتمل أن تكون normal or reduced or absent in the spinal cord lesion. They are absent in the peripheral nerves lesion, and they are reduced or normal in muscle lesion. بعد ما أدينا أو after reviewing these three steps and clinically, and you decide that you are most likely in the spinal cord level or in the peripheral nerve level or in the muscle level, and we are discussing these three levels because we said acute flaccid paralysis, there is no CNS symptomatology, so most likely we are dealing with the lower motor neuron unit. Now, if you decide that you are most likely in the spinal cord, then you have to consider the spinal cord lesion, acute transverse myelitis, tumor, AV malformation, stroke, etc. It depends on the history and the examination. In the peripheral nerves, we have either bilateral or unilateral involvement, unilateral weakness, or bilateral. Then if it is unilateral, we are dealing with enteroviral infection or local trauma. If it is bilateral, we are dealing with something more systemic like post-infectious autoimmune disorder like Guillain-Barré syndrome or toxic neuropathy. With the muscles, most likely we are dealing with post-viral myositis, periodic paralysis, and toxic. In all at the three levels, you must start with the acute flaccid paralysis workup. Acute flaccid paralysis workup we will talk about later, but the next investigations depend on the localization of the disorder. In the muscle, you are going to do creatine kinase, serum electrolytes, and urine myoglobin. In the peripheral nerves, you are going to do nerve conduction study. And optionally, you might need MRI for the plexus or the sciatic nerve. For the spinal cord, you need to do neuroimaging, which is spinal cord MRI plus CSF changes with other optional investigation that depend on their choices depend on the clinical history and the other findings. The most common causes of acute flaccid paralysis that are encountered in our clinical practice is the Guillain-Barré syndrome. Poliomyelitis incidence was dramatically reduced after inclusion of the polio or after the application of the polio or the vaccination schedule. Guillain-Barré syndrome has a classic story or a classic clinical course. It is an immune-mediated disorder. Immune-mediated means there is something is happening, like infection or trauma or surgery or whatever, but the most common preceding event is the infection, which induce the immune system. So you will expect the the neurological features to start after a period of time from the onset, from the preceding event. The male and female have similar risk, and the most common age group is 4 to 9 years. It can be seen, but rarely in as young as 1 year and in as old as 95 years. There are types of Guillain-Barré syndromes. The most common type is the AIDP, the acute inflammatory demyelinating polyradiculoneuropathy. The story, there is a demyelination. Most likely there is segmental demyelination, and to lesser extent there might be axonal degeneration, or there might be combination of both. It involves the peripheral nerves and also the peripheral nerves and even the cranial nerves. The clinical feature, as we said, there is infectious event in 60% of the cases. Most likely GIT infection like Campylobacter or respiratory tract infection like Mycoplasma, followed by onset of a neurological manifestation, which is weakness. The weakness is usually ascending, involving the lower limbs, and then ascend to the trunk and the upper limbs, and after it causes bulbar weakness. It is symmetrical or relatively symmetrical, but in 9% it is asymmetrical and should be differentiated from other causes of asymmetrical or unilateral acute flaccid paralysis. It could be abrupt or rapid. The child is irritable because of the sensory changes. There is paresthesia. There is no sensory loss, but there is paresthesia. 50% bulbar involvement, involvement of other cranial nerves like facial nerve, third, sixth, 10th, ninth, etc. Sometimes meningeal signs can be found. Papilledema rarely, it is unexplained and rarely seen. Respiratory muscle can be involved. We need for the diagnosis is a clinical. For the diagnosis, you need two important and essential criteria: progressive motor weakness of more than one limb. نأكد على هذه الخاصية. And areflexia or hyporeflexia with the involving the affected limbs. So the diagnosis is a clinical first, and we have other additional supportive tests like lumbar puncture, where the CSF here the neuroimaging is not indicated in patient with acute flaccid paralysis and suspicion of Guillain-Barré syndrome, but it is needed and should be considered in the following conditions: when the presentation is acute or rapidly progressive, when there is a predominant sensory symptoms, predominant sphincteric changes, clear sensory or marked motor level. Lumbar puncture most likely show, especially after the first week, most likely it shows elevated protein and normal cells, or mild increase in the white blood cell, and most likely which should be most likely lymphocyte. And this dissociation is called albuminocytological dissociation with normal glucose level. Neurophysiology can be normal again in the first week, can be. And later in the demyelinating type, it shows conduction block, decreased compound action potential amplitude. Other investigations should be checked if we are not sure. The most important is, as we said, the clinical feature, or the two important clinical criteria. Additional supportive test is the electrophysiologic and the CSF. These are additional investigations that might be done, especially if there are some suspicions. The treatment, first of all, we are dealing with acute flaccid paralysis. For any case, we have to admit the child because it is an emergency case. Second, you can give either IV immunoglobulin or a plasma exchange. The third, and the most, actually it is the most important thing, it is the supportive treatment and the rehabilitation. You have to treat the child symptomatically. You have to treat the pain. You can see here the supportive, we want to get rid of these autoantibodies. We can do plasma exchange, but the plasma exchange is not available every time, and especially in the pediatric age group. You can give IV immunoglobulin. Again, it is costly, expensive, and cannot be afforded every time. Yet it is easy to be given. Practically, it is more feasible and more practical. It causes side effect, and the dose of IV immunoglobulin is 2 grams per kg. This is for the total course. It can be given over 2 to 5 days. Corticosteroid is not recommended. Managing pain, this is important. You need to manage the child with supportive treatment. You need to check his blood pressure, his cardiac function. Sometime, especially for older children, obese children, you can give a prophylactic anticoagulant. You have to maintain bladder and bowel function to ensure their function. And if there is any problem, because sphincteric changes can occur in 5 to 10% of cases of Guillain-Barré syndrome in children. You have to maintain normal, good nutrition, fluid, and electrolyte. You have to treat pain, skin. You have to prevent any corneal damage because of facial nerve injury. Uh, and you have to treat infection. About 40% of children with Guillain-Barré are bed-bound. 15% required ventilation. Those are very important. This is very important group of children. They are risky children. 90 to 95% will have complete recovery within 6 to 12 months. We can tell the parents, we need to tell the parents these percentages. The causes of death can occur in about 4% of the cases. Causes of death can be autonomic problem, respiratory failure, pulmonary embolism, complication of ventilation, or cardiovascular collapse. And then we will talk about poliomyelitis. Again, we have to remind you that poliomyelitis incidence was reduced because of the use of vaccination program, regular vaccination program. It is caused by RNA virus, the polio viruses. There are 3 genetically distinct serotypes. Fortunately, 90 to 95% of the cases are causes inapparent infection. The transmission is fecal-oral, and there is a need for isolation for 2. It can be so that the viruses can be isolated from stool for 2 weeks before the paralysis and several weeks after onset of symptoms. The virus goes through the GIT, passes to the regional lymph node and through blood causing viremia, and later the clinical feature will be decided, or the clinical course will be decided. As we mentioned before, 90 to 95% there is inapparent infection, no disease and no sequelae. 5% there is abortive disease, flu-like illness. 5% flu-like illness. 1% there is abortive type of disease, flu-like illness associated with some stiffness, knuckle rigidity, changes in the reflexes, deep tendon reflexes, but there is no sensory defects because the problem is in the anterior horn cells, which are motor cells. So there is 90 to 95 inapparent, 5% abortive, 1% the non-paralytic polio, which is abortive with some stiffness. And there is the paralytic polio, which is either spinal, bulbar, or polioencephalitis. The classic spinal polio or spinal paralytic polio accounts for 0.1% of the cases. The major phase is a parasthetic phase. The child is irritable and looks discomfort. There is some fasciculation and spasms, which progresses into asymmetric paralysis of one leg. First of all, there is irritability, there is paresthesia, and the next feature is the weakness of one limb. Deep tendon reflexes is diminished or absent at this period, and there is variable course. This is the spinal. It could be bulbar. It causes all the features. This is the list of features that is caused or resulted from bulbar impairment. It could be polioencephalitis, encephalitis-like picture. How can we diagnose? We should consider poliomyelitis in any risky group. The risky group or the risky child is any child unimmunized or completely immunized. Unfortunately, rarely the lesion or this poliomyelitis form can be caused by the vaccine itself, but this is very rare. How can we diagnose clinically first, especially if we are dealing with asymmetric acute flaccid paralysis? Then we are going to do the AFP, acute flaccid paralysis workup, by collecting the stool to isolate the virus. 2 stool specimens collected within 24 to 48 hours apart. And in the first week, we can isolate it. The isolation yield is positive in 80 to 90% of cases. And this percentage is reduced in the subsequent weeks. The CSF is normal in most of the cases, but initially there might be high cells and then reduced. The protein is low and increased to up to 50 to 100 milligram per deciliter in the second week. CSF serology can be done. Treatment, there is no specific treatment. It is the main treatment is the supportive treatment to limit the progression, to prevent skeletal deformity, to prepare the family for the prolonged treatment. For the abortive, for the abortive poliomyelitis, we need to give analgesic and sedatives and attractive and diet with bed rest until temperature normalized. For the paralysis, we need to hospitalize the child, physical rest, change the position every 3 to 6 hours, active and passive movement, moist hot packs, etc. For the bulbar, we have to maintain the airway and to avoid risk of inhalation, and to maintain the fluid and electrolyte equilibrium, and to check and to monitor the autonomic function, especially the blood pressure. The prognosis for the inapparent, the abortive, and the aseptic meningitis form, it is of good outcome. For the paralytic, it depends on the extent and severity of CNS involvement. If there is severe bulbar involvement, the mortality rate is 60%. How can we prevent poliomyelitis? By vaccination and good hygienic measures. Thank you.